All right, we can start. So hello, everyone. My name is Alexandre Georgeon. I'm global sales and marketing for the company Regedent. I'm happy to welcome you today on our webinar with Professor Božić here today. Good morning or good afternoon, Professor. Today we have a great topic. We'll discuss the new approaches in GBR procedure by Darko Božić. Next slide.
Wait, I don't know why it's not moving. Here it is.
Exactly. So Darko Božić is a specialist in periodontology. He's an associate professor at the Department of Periodontology at the School of Dental Medicine in Zagreb, Croatia. He works in the Croatian's biggest university, clinic hospital, at the Clinic of Periodontology as a specialist in periodontology. In addition to that, he also works every day in a private practice in Zagreb. Currently, he holds the position of the president of the Croatian Society of Periodontology. He has been a long-time Croatian delegate to the EFP, a position which he left in 2017. Since 2016, he has been the EFP webmaster and member of the communication committee, for which he has been elected for another 3 years term. The focus of his research is proteomic analysis and periodontal tissues, for which he and his team have received 2 prestigious IADR awards in 2015. Second place, Hatton Unilever's Senior Clinical Research Award, proteomic analysis in gingival tissues in patients with aggressive periodontitis. In 2014, he got the second one, IADR PER in Dubrovnik, Croatia, where it was the first place Robert Frank Senior Clinical Research Award, proteomic analysis and gingival tissue in patients with aggressive periodontitis. His main focus in his clinical work and research is the reconstruction of soft and hard tissues in periodontitis, affected patients with a special research interest in the application of growth factors, namely BMPs and hyaluronic acid, the topic of today. He's as well specialized in soft tissue reconstruction utilizing various collagen matrices. He lectures extensively on the national and international level on various topics with more than 60 invited lectures so far, many at international periodontal congresses such as Europerio meetings and other international periodontal congresses, such as the Perio Master Clinic in 2020. He frequently gives advanced clinical master courses with live surgery procedures worldwide. That's about the profile of Professor Božić. I can hand over the microphone to you, Professor.
Thank you very much, Alexander, and thank you very much for everybody that is currently here today for this webinar. It is my pleasure to welcome all of you and to greet all of you. And I see there's a big bunch of people from all around the world, which is very nice and very interesting for me. I will turn off now the camera now that I said hi to everybody, and I will turn it on later again when we will have questions and answering. So I will just keep the microphone on. So the internet is a little bit slow. Sorry for that. So, okay, the topic of today would be new approach and GBR procedures utilizing hyaluronic acid. And the outline of the lecture would be biological basis, which are behind this concept in bone regeneration, and the changes that have been going on in the last 2 years, how we changed and shifted our approach in utilizing this molecule for bone regenerative procedures. So when we look at the trends in dental implantology, there's a nice article published in 2018, which actually shows that from 2000 to 2015, there was a 15% increase in prevalence of implant placement. And there's an estimation that in the next 6 years, there's going to be an implant prevalence of increase of about 23%. So we see that there's a high demand of implant placement in today's world, and annually there's around 22 to 23 million of implants that are placed up to date. So the problem is that we frequently don't have enough bone to place our implant in a prosthetically correct position. So how frequently are these procedures? There's a very interesting study from a Korean group published in 2016, and they looked at how many sextants they did surgery on from 2006 to 2014. They placed 1,512 implants, and 50% of the sextants needed grafting. So it means that actually every other implant needs a bone grafting procedure. So implant positioning was around in the distal maxilla was 40%, and then the distal mandibles 36%, 127 sextants were in the anterior maxilla, and the anterior mandible was around 7%. And the sinus left lateral approach was in 22% of the cases, and the GBR was in 22% of the cases. So, but 50% of the sextants needed bone grafting, and especially in 78% of the cases in the anterior maxilla, they needed grafting. So we see that there's a huge necessity of bone regenerative procedures with implant placement. So when we talk about it, is a hyaluronic acid a new emerging aid in these procedures? First we have to say something about the mechanisms of wound healing. This lecture would be a little bit enhanced lecture from the one that I gave in the PeriMaster Clinic in Dublin 2020, a month ago. So we'll see a few new cases, a little bit more expanded than I had time there a month ago. So hyaluronic acid is a major component of the extracellular matrix, and in its native state, it exists as a high molecular weight molecule, which is very important. We will see this later. So there's a certain difference between what does a high molecular weight molecule and low molecular weight molecule. What they do is the high molecular weight molecule exhibits higher viscosity, longer resistance time, and higher biocompatibility. And it also shows anti-inflammatory effects. So it inhibits angiogenesis, decreases interleukin 1 and 6, TNF-alpha, and prostaglandin E2 production. Low molecular, on the other side, stimulates angiogenesis and induces inflammatory effects. When we look at the angiogenesis and the ability to produce new blood vessels, there's a very interesting study in 2011 that hyaluronic acid actually stimulated neovascularization during the regeneration of bone marrow after ablation. And down here we see that both the high molecular weight hyaluronic acid combined with demineralized bone matrix and low molecular weight with demineralized bone matrix significantly increased blood vessel volume. So this is very important. So we know that it increases angiogenesis, which is crucial. When we look at how hyaluronic acid works on fibroblasts, on soft tissue cells to induce faster soft tissue healing, there's a study published just last year. They had 2 preparations of hyaluronic acid, and they looked at the human gingival fibroblast and the human palatal fibroblasts. And the conclusion was that both formulations were able to enhance the proliferative, migratory, and wound healing properties of cell types involved in soft tissue wound healing following regenerative periodontal surgery. So we see that it increases or enhances soft tissue healing. That's one of the important. The other very important thing is the receptor with which the hyaluronic acid binds, and that is the CD44 is the predominant receptor for hyaluronic acid. And another important thing is that the higher molecular weight of HNA, the more binding sites for CD44. In addition that hyaluronic acid binds to CD44, this transmembrane receptor is expressed by many cell types, especially mesenchymal cells, which is we will see later again, a very crucial, important piece of biological information for us. In the periodontal ligament space, it's also very important that we see that CD44 is actually very important for proliferation and mineralization of PDL cells. And we can see that when we have a CD44 knockdown, we see that on the right side that CD expression is stably knocked down in PDL cells, their proliferation and mineralization was substantially decreased. And look at this alizarin red staining. So the mineralization process significantly decreased if you don't have CD44 in the cells. But how does the activity work on bone cells and bone formation of the activity of hyaluronic acid? A long time ago, like 25 years ago, Sasaki and Watanabe published this in Bone in 1995, and they show that high molecular weight hyaluronic acid actually accelerates new bone formation through mesenchymal cells differentiation in mouse bone wounds. And they have been able to show it that it really is able to increase new bone formation in these defects. Another study published in 2003 also showed, when they looked at how does hyaluronic acid work on alkaline phosphatase activity and the upregulation of osteocalcin, it showed that high molecular weight hyaluronic acid, like 2,300 kilodaltons, significantly increased all parameters like the degree of mineralization, the alkaline phosphatase activity, and the upregulation of osteocalcin expression in mouse calvarial osteoblasts. So another interesting study, another study on bone marrow stromal cells also showed that hyaluronic acid has an important role in early and late stages of bone formation and can increase proliferation and osteogenic differentiation of bone marrow stromal cells. And we see it here with pictures from A to C. We see it that alizarin red staining significantly increases if we add hyaluronic acid to these osteogenic differentiation to these bone marrow stromal cells. Additionally, there is always a still kind of under some confusion, or let's say we're not very sure what is the difference between different molecular weights, how the function is of these different molecular weights. And this study published in 2015 by a Chinese group, and they looked at rabbit bone marrow derived stem cells. They found that high molecular weight hyaluronic acid increased messenger RNA expression of alkaline phosphatase, RUNX2, and osteocalcin. The higher molecular weight, the higher the messenger RNA expression was. So we see that it is very important to have a relatively high molecular weight of hyaluronic acid if you want to have bone formation, or at least you want to have expression of genes that are associated with the mineralization process of cells. We see it additionally, very interesting, hyaluronic acid is very popular as a carrier for growth factors as well, but this is a different topic. But we see that in this study in 2016 that the hyaluronic acid by itself was able to induce osteoblast differentiation, and especially even more so when combined with BMP9, which is a very potent molecule for bone formation. So, but even by itself, hyaluronic acid was able to induce osteoblast differentiation. And when we look at the signaling, some of the evidence shows us that it maybe enhances the BMP2 signaling pathway when combined with BMP2, and it actually, what hyaluronic acid does is downregulates BMP antagonists such as noggin and follistatin, which is also very interesting. So how does it work in, let's say, bone regeneration? We know some of these biological principles behind the molecular events, what it does to it. There's two very interesting studies by the same research group from Korea. And what they did is they actually made chronically infected extraction sockets. So they induced a combined endoperial lesion, then they extracted the root, and then they placed hyaluronic acid within the root. And what they found is actually, and on the other control site, they didn't place anything. What they found is that in the extraction sockets where they actually added hyaluronic acid, that they had much more mineralized bone, 63%, and less bone marrow compared to the control group. In the control group, it was like 50-50%. In the test group, there was more mineralized tissue. And we look, compare the histologic from the control and the test, we see much more mineralized tissue in the test group as compared to the control group. And then they made another study, and the same model, and they wanted to compare the hyaluronic acid to BMP2. So they had 4 groups. They had the control group, they had the group only that received the absorbable collagen sponge, then they had the group where they had the hyaluronic acid gel with the absorbable collagen sponge, and then they had the 4th group where they had recombinant human BMP2 with the absorbable collagen sponge. And they basically used, again, the same concept where they made a hemisection of the tooth, extracted 1 root, waited for the combined endoperial lesion to develop, to have a chronic defect, infected chronic defect, then they extracted the tooth, and then they went on by dividing into one of the 4 groups, the animals. What they found is actually, and we look at the micro CTs here, we see that E and F is hyaluronic acid and G and H are BMP2. So what they found is that the application, and the conclusion was that the application of hyaluronic acid with an absorbable collagen sponge in compromised extraction sockets provides enhanced regenerative efficacy for bone healing compared to BMP2, which is quite interesting because we always think that BMPs are basically the holy grails of bone regeneration and the most potent molecules of bone formation that we know there. And actually, they suggested that they can be effective in guided bone regeneration and can be, and their utilization or usage can be expected in challenging GBR cases. So why is that important? Because BMPs actually have been shown that they're the only molecules that are able to induce ectopic bone formation. That means bone formation non-skeletal sites. And if we have something like a hyaluronic acid that is able to do and to produce similar results or almost same results as BMP, well, this is for me very interesting. So everybody that wants to read something, there's a very good article just came out recently, a review article on the application of hyaluronic acid in bone regeneration, very informative. You have all the information there. And the conclusion of this article is that hyaluronic acid should be considered as a promising tool in bone regeneration, and that hyaluronic acid derivatives or hyaluronic acid incorporated composite scaffolds have shown excellent potential for improving osteogenesis and mineralization. And when you think about all of this, and when you start, rotating your mind and your thought, then you come up with a device which I will show you. This is and the concepts, how it changed over the last 2 years, and how I came to the results I am achieving now, which is for me now the standard of care. All of the results here obtained are done by this hyaluronic acid. By HAD and BG, it's a cross-linked hyaluronic acid of concentration 1.8. 1.6 of cross-linked has a molecular weight of 1,000 kilodaltons, and then we have 0.2 natural hyaluronic acid, which has even a higher molecular weight. And we talked about the importance of a high molecular weight in order to get all of the osteogenesis and the potential of the cells to go into the osteoblastic lineage and form mineralized tissue. So one of the cases that I did, one of the first cases a few years ago that I did, was this case where the patient had an external root fracture and external resorption. So this tooth had to come out. We can see that there's no bone buccally and no bone palatal on the palatal side. And the tooth is extracted, and after 4 to 5 months, we have a defect like this. So we have to do a vertical augmentation and a huge horizontal augmentation in this patient. And in this case, there's no autogenous bone. So this is only xenograft and allogenic bone mixed together, combined here with hyaluronic acid, impregnated a lot with, pre-coated with hyaluronic acid, and then again stabilized with hyaluronic acid. And and in this case where I had to do vertical augmentation, I use non-resorbable membranes such as this. And then I always cover them with resorbable membranes to protect the soft tissue during the initial 2 to 4 weeks of soft tissue healing. And 6 months later, this is the amount of bone formation that we get. This is a huge block of bone, and you always see underneath these non-resorbable membranes the layer of around 1 millimeter of pseudoperiost, which I don't remove. I always keep it to protect the bone that has developed underneath. And the implant is placed in a more palatable position, in a 3-dimensional position, basically only in regenerated bone. So this implant is placed completely in regenerated bone. And this is the end result after playing with the provisional and everything. And we can see an acceptable and pretty nice aesthetic outcome of this case. But the point is that these non-resorbable membranes usually pose a problem. And my idea is to simplify the procedures. And in 2009, actually in 2018, I was involved in the prestigious European workshop. And I was in the group that was devoted on bone material, biomaterials and regenerative technologies. We were the working group 2. And one of the consensus reports we made when we talked about membranes is that the membranes have to be biocompatible, they have to be biologically active, they have to have a certain porosity and occlusive properties, they have to have certain mechanical properties to resist the forces of the musculature and the biting and chewing, and they have to integrate with the surrounding tissues, they have to tolerate the exposure and not get infected, and they have to be biodegradable. So how does hyaluronic acid affect? Well, hyaluronic acid can affect these three things: the biological activity, the mechanical properties, and the biodegradability of it. And how does it actually do that? Well, it was shown that if you immerse collagen membrane in hyaluronic acid prior to the implantation, there's a delay in the membrane degradation. So we prolong the function of this membrane. So it delays the degradation, and it stays for a longer period in place, and it does not resorb so fast. Another important thing is that the hyaluronic acid is absorbed to the collagen membrane, and then it is slowly released into the surrounding medium, which is very interesting, because basically maybe the membrane is functioning as a scaffold for the hyaluronic acid to work to the surrounding cells. So what I want to do is I want to simplify, and I was trying to find a way to simplify the procedures that I don't want to harvest too much autogenous bone, that I want to reduce the morbidity because of that. I want to reduce the rate of complications, and as much as I can, I want to avoid using non-resorbable membranes because of the problems that they do. Of course, you have to use them in some cases, like vertical augmentations. So, but as if with every material, there's a learning curve. And this learning curve, I will go with you through this learning curve over the last 2 years. In these next 20 minutes is the last 2 years. So one of the first cases, you know, you always choose a little bit relatively less risky case for the first cases. And this is one of the first cases where, you know, the width of the ridge was around 4 millimeter. And it was barely on the limit, because if we want to place a 4 millimeter diameter implant in a first molar position, then we need at least 6 millimeter width of the ridge. And I will show you the surgical video of this case. So I always make a crestal incision distal, and then I make one more mesial vertical incision, and I immediately go and do releasing incisions in the periosteum immediately, because then the bleeding is less, and there's less hematoma. And we have to clean the bony surface and remove all of the soft tissue that are remaining there. And additionally, we have to release the lingual flap as well. And with these special burrs, I harvested a lot of autogenous bone because we were always taught that we need autogenous bone, always that we need autogenous bone when we want to combine it with a xenograft and a collagen membrane. So this is how it looks: autogenous bone, xenograft, all of it impregnated with hyaluronic acid. And I go there and I fix my resorbable collagen membrane, actually the pericardium membrane, with a few tacks all around. And then I went in and started filling in the defect with the particles, with xenogenic particles mixed with autogenous bone and impregnated, pre-coated with hyaluronic acid. And we go layer and layer and we fill it up and we overfill and gently push it inside. And then I went again, and then I placed again hyaluronic acid over everything one more time to stabilize the grafting material and make it something like sticky bone. And then we go and place the collagen membrane on the lingual side. We cut membrane and we stabilize the membrane again on the lingual aspect. So this was one of the first cases. And 6 months later, I get this. Nothing spectacular. You know, it was maybe 0.5 millimeter more. So this result was a little bit, very nice incorporation of the grafting particles, very little residual particles there, not embedded. It all looks healthy and it all looks vascularized, but I was not so satisfied with this result. And then there was a turning point after maybe 2 more cases that I've seen relatively good results, but not what I expected. This case is a clear example how things started shifting and changing. So we see a relatively narrow bilateral distal mandible where we have to do a GBR procedure prior to implant placement. And on this side, I decided to use very little or almost no autogenous bone and use only hyaluronic acid and xenograft. And this is how it was, like this. And on the other side, I drilled autogenous bone and did it the same as the patient before. And again, impregnated everything, encoded. And this side is how it looks on this side. Quite okay, but nothing special. But on this side, I have much better results. I had a much wider ridge. I had a ridge where I could easily accommodate a 4.5 implant and the molar position. So this was a turning point. And from there on, I actually started using less and less autogenous bone, and I will show you the concept and how and why. So in this case, we see a one wall defect where in order to place an implant in the position of 4-7, we need to do a significant regeneration. And some autogenous bone harvested, mostly cortical, but in this place here, only drilling to the marrow spaces. So a lot of drills to the marrow spaces. And everything coated together with hyaluronic acid. And then a shift, another shift. Less autogenous bone, but actually it's a 2-layering system. In the inner part, small particles. In the outer part, larger particles. And this is how it is. So in the inner part, there were smaller particles, and in the outer part, I started placing larger particles here. And if we look at 6 months later results, so in position 4-7, we had a 3.36 millimeter width of a ridge, 1 millimeter below the crest. And position 4-6, we had a 5 millimeter wide ridge. 6 months later, we have in position for 7, we have 7.62. And in position for 6, we have a 6.69. So we have a significant increase. Here we got almost 4 millimeters of horizontal gain. So, and here we got 1.7, almost 1.7 millimeters, a little bit less. So the wider the ridge, the less you get. So, and this is how it looks when the implants were placed. And you can observe that there's almost no visible residual particles, that everything is remodeled very fast, and you don't basically see any grafting materials here anymore. So why do I think, and what is the concept behind this? It is the concept of these osteomacs and osteoimmunology, these multinucleated giant cells, which actually are frequently found around grafting materials. And there is evidence that these cells actually induce vascularization and new bone formation. And how does it work? It works that if you remove osteomacs from in vitro culture systems, you have a 23-fold decrease in mineralization. And depletion of osteomacs in vivo has shown to markedly reduce bone formation. So we need these cells. In bone modeling, depletion of osteomacs leads to complete loss of mature osteoblasts in bone modeling at the bone interface. And furthermore, in bone remodeling, osteomacs are obvious candidates to detect and respond to bone damage, a critical event in osteoclast recruitment, thus initiating the bone remodeling phase. So they work on multiple levels in bone formation. And since then, I basically don't use any more autogenous bone. We observed this case in the anterior maxilla, and the Cbct shows us that there is really a lot of bone loss, a very narrow ridge, We have to reconstruct relatively a lot of bone. And I graft in this case in the palatal and on the buccal side, left and right. You can see it, you can see it here. Covered everything only with a collagen membrane. And 6 months later, this is on the right side, and this is on the left side. And this left side, we even had an infection, and I had to drain the abscess. So there was a bad abscess, and I thought I was going to lose all of the grafting materials. But as you can see, there's very little residual particles. And the implants were being able to place in a prosthetically correct position. And with very thick, these ridges, these implants are 4.3 in diameter. So it's around more than 6-7 millimeters of width ridge that I've been able to achieve here. Let's look at this case here. Distal mandible again. On the crest, we have 2.15 millimeters, which is almost exactly the same as with the periodontal probe. And 1 millimeter below the crest, we have 3.8 millimeters of the width of the ridge. And always the same concept now, small particles in the inner portion, larger particles in the outer portion, only a collagen membrane. And if we look at 6 months later, the width of the ridge is 7.37 and 7.77, so almost 8 millimeters. So there's more than 4 millimeters of gain of the width of the ridge. So now you can place the implant in a perfectly positioned prosthetic position. The other side of the same patient, it's 3.61, 4.49, and in the distal part here we have a 3.5 and 3.42, so there's only 3 millimeters, and there's also a lingual part that has to be reconstructed. The same concept, drilling of the holes, no autogenous bone harvesting. We can see small particles and large particles. And this is the width of the ridge. So we went from 3 millimeters to 6 and 6, and even distally even more, we went to 7.7 and 7.6 millimeters. So we can position the implants in perfect prosthetic position. And listen to the sound of this if you don't think it's bone. So this is all reconstructed bone. And if you think that that was only one case, well, I can tell you this is the standard of care for every single case in the last year that I have been doing. So let's look at this last case here. So we see that 1 millimeter below the crest, we have 3.16 or 3.3. And the more distal part, we have 2.38 and we have 3.17. So here distally, we have a little bit even less bone width. And we have only a 7.8 millimeters in the zone, which is 1 millimeter above the mandibular channel. So we are also limited by the height of the mandible. So we really have to do a good reconstruction to keep in the safety zone, which is at least 1 to 1.5 millimeters above the mandibular nerve. So we see, so there's drilling. That's the only thing I do. I drill from the buccal and to allow the cells to come out from the marrow spaces. So small particles, large particles. And this is how it looks 6 months later. And you see very little residual particles. You see the difference and how things have been changing over the last 2 years, how we now are getting more and more better results. And there's very nice embedment of this newly formed bone here to the old host bone. You vertically don't see any residual particles that are not embedded and that are not vascularized. And if we look at the Cbct before and after, we see that we went from 3.16 to 5.77 to 6.0. We see that we went from 2.38 and 3.12 that we went to 7 millimeters. So we gained 4 millimeters. We frequently gain around 4 millimeters of horizontal gain with this approach. And additionally, we see that we can place a 4x7 or 4.5x7 implant, and we're in the safety zone now here, that what we can do. And this case also, look at the sound of this. I mean, it sounds like bone to me, definitely. So the conclusions of this short webinar and this quick show of how things evolved over the last 2 years is that hyaluronic acid has the potential to induce bone formation for creating a favorable biological environment. There is fast bone remodeling when these molecules are utilized, and there are visibly very little remaining grafting particles. It seems that xenogenic bone alone, combined with hyaluronic acid and a collagen membrane, is efficient for horizontal bone augmentation. And I'm waiting for the human histology. We did around 20 patients now, and we have around 15 human histological samples that have been taken. And hopefully, and let's say in the next 6 months, we will be able to show the quality of this newly formed bone and the micro CT analysis, so that then we are fully convinced that this is really new bone, and the amount of remodeling, how much is the amount of the remodeling and the remaining grafting particles within these bone core samples. And unfortunately, this is our world now today. COVID is a reality, and we have to endure, and we have to keep safe, and don't walk around too much. And you know, with this, I would like to thank everybody, of you almost 500 people here that have been listening to this webinar. And I'm now ready for your questions. I will start my video, and thank you very much for your attention, ladies and gentlemen.
Thank you, Darko. So we are getting some questions in the Q&A part, not in the chat, in the Q&A again. Please post it there. Darko, I'll let you select the one you can answer.
Okay, so we'll go from the beginning. Okay, what type of tacks do you use? I use Botis ones. You can use any. I use the 3 millimeter height one, because the 5 millimeter ones are very are not difficult to use. They like to break, and it's not easy to tack them into the bone, especially if you have thick cortical bone. Then it's not so easy. So I use 3 millimeter high from Botis or any other producer. How much time do I wait for putting the implants? I usually wait 6 months, but I can tell you one thing is that some patients came after eight months, and I'll tell you there's a big difference in remodeling between the 6 and 8 months. After 8 months, it looks even much better, much better. What tax do I use? I already answered it. In which case do I use a membrane? I use a membrane in every case. And in 90% of the cases, I use the resorbable membrane. But there are resorbable membranes and resorbable membranes. For this concept that I'm talking about, you need a resorbable membrane that is elastic. So the one that I'm using for the last, I don't know how many years, is the one from REGEDENT. It's a very good porcine pericardial membrane, which is very elastic. Once you soak it, you can spread it, you can stretch it, and it will not tear. So you need a membrane that you can stretch that will not tear. Okay. How do I provisionalize the regenerated area during the bone healing? Well, in the distal mandible, I don't do anything. I mean, if the patient has the last tooth of the first premolar or the second premolar, they're okay. And the maxilla, it's a little bit, it's in the maxilla, if I can keep their natural tooth, then I use this natural tooth as a provisional restoration. Otherwise, you can use a Maryland bridge, which we frequently use. So we make it in the lab, and that's one of the things that. I don't use hyaluronic acid with Emdogain. Well, it's very difficult to stabilize the mix of the xenograft. The question is, how do you stabilize the mixture of the xenografts in hyaluronic acid without the membrane? Well, it's virtually not possible, at least not in my hands, because it's very important to get the right ratio of hyaluronic acid in the construct. If you use too much hyaluronic acid, then the blood that is flowing from the perforations of the bone is going to take away your xenograft. So don't use too much of hyaluronic acid. Don't make it more liquid. Make it as a sticky bone. So it has to be like a sticky bone, and then apply it. The point is, I would have to show you how to get the right consistency, how to rate. The next question is, which are the healing period before implant placement when you use Xenograft? I said the minimum is 6 months. 6 months. How do they look like, the histologic samples of the Regeneration? Well, you'll have to wait. I'll have to wait, and you will have to wait for some time. But clinically, it looks excellent. Clinically, it looks excellent, especially. Can we have scans for 10 years or 15 years of healing? Well, hyaluronic acid has not been there for 15 years, at least not in so much. I can show you only what I've been doing for the last 2.5, 3 years. So that's the only thing I can show you. Do you do simultaneous implant placement and bone augmentation? Yes, sometimes if I have a 2-wall defect or if I have a 3-wall defect. If you have a 1-wall defect, then I'd rather not use it. But you can use you can use, if you want, you can use a titanium mesh or another non-resorbable membrane in these cases. But I prefer to do 2-stage procedure. So I do 1-stage procedure, and I do it simultaneous bone and implant placement, bone regeneration and implant placement. But my preferable approach is 2-stage procedure. First, reconstruct the bone. Then usually you have to reconstruct the soft tissues, and then you place the implants. Well, I don't have 5-year follow-ups. I have only 2-year follow-ups. So 5-year follow-ups, I still do not have. Are residual parts in new bone bad? Well, you don't want to see dead particles. You frequently see, as many of you probably have seen, when you place a xenograft, you sometimes see, well, not sometimes, very frequently you see that the xenografts are embedded in the soft tissue of your flap. And if we're honest to each other, then you frequently see, or sometimes you see, that the xenograft material is going out through the soft tissue once you did a GBR procedure. Now, if you tell me that you've never seen this, then this is quite not the truth, because this is something that does happen. Now, when I use growth factors, being either PDGF or Emdogain or BMP or now hyaluronic acid, I never see these non-embedded particles, or very, very, very little, very little. So there's definitely a huge advantage of using this molecule in GBR procedures. When do you need a vertical augmentation? Do you use a well, in vertical augmentations, I prefer a non-resorbable membrane still. I'm absolutely positive that for vertical augmentations, you really need a non-resorbable membrane. Maybe you can do it with a collagen with tenting screws, but you will for sure, if you look at all the articles by Jovanovic and Urban, a non-resorbable membrane is still the membrane of use for vertical augmentation. EMD is Emdogain, enamel matrix derivative. For bone augmentation, I use Xenograft material. I exclusively use the Xenograft material. I used two materials in these cases. One is, oh my God. So one is BIOS, definitely, and the other one is, which I use in 80% of the cases, is, sorry, I'll get back to you. You see, I forget these names. Well, I see my good friend Giuseppe Romito here. Can you explore more why you've stopped using autogenous bone mixed with xenograft bone? Thanks. Well, it's simply because I've seen that I get better results when using only xenograft. I know this sounds strange, and this goes against the paradigm that we need autogenous bone. But all of my cases where I used a mixture of, let's say, 60 to 40 or 70 to 30% of xenograft and autogenous, I've seen not as good results as in these cases where I used only xenograft. I know this sounds strange, but the biology behind it, which I try to explain, is for me clear. Because if the autogenous bone resorbs very fast, then unfortunately the hyaluronic acid is unable to have its effect on autogenous bone. So I don't know if you're happy with the answer, but I see simply much better results in the concept that I've showed you in the last cases. Much better results. In a site extraction with more vertical bone loss, will you place the collagen sponge or HNA, or just in these cases? So I've been doing these cases. I use a xenograft with hyaluronic acid, and above that, I only place like a collagen fleece or some similar material that is not expensive, that is very cheap, and it works very nicely. How much do you wait for hyaluronic acid used in GBR comparing when you're not using it? I always wait 6 months, whatever I do. And the 6 months, I think 24 weeks, we know that, when you have when the bone fractures, it takes you 24 weeks for the bone to heal. So 6 months is 24 weeks is 24 weeks. I would not go earlier. If you use only autogenous bone, you can go in after 4 weeks, but that's only. What do I mean by small particles and big ones? Small particles are the ones that are up to 0.5 millimeter, and big ones are that are 1 to 2 millimeters in size. So if you use only small particles, you get a little bit less results. It's much better to put small particles, xenograft small particles in the inner part, and larger particles, because the larger particles get very nicely embedded and they incorporate fantastically. I don't know why it is like that, but it is quite unbelievable, and this is the only concept I have been using. Let me go further. The regeneration and mineralization of the new bone are accelerated by using hyaluronic acid. For me, from what I see, absolutely and definitely yes. Thank you very much. Thank you. Thank you for the. Can you tell me, do you always stabilize the collagen membrane? Yes, it is mandatory. Mandatory to stabilize with the pins or any other way the collagen membrane. It must not move. It has to be, and the material underneath it must be packed, tightly packed, tightly packed. So when you press your finger on the material, it must not move. So you have to pack it underneath very, very strongly, very strongly. Hello from Colombia, hello from Croatia. How do you calculate the hyaluronic? How do I calculate the amount of hyaluronic acid needed? It's a learning curve and a learning experience. In the beginning, I added a lot, which was too much. Then the construct of your material is more liquid, and you don't want that. So you want it to be more like sticky bone, okay? So I would advise you to first add a little bit, and then as the grafting particles start to connect, add more and more, and then you can pick it up like this, and if you see that the particles are all together stuck, then that's enough. That's enough. Don't add any more. Don't add any more. Do I put implants in narrow ridge and do GBR? Before I would do it a lot, especially in the distal mandible, and I would usually use the titanium mesh, which is the only membrane in these narrow ridges that really works. The collagen membrane didn't work in my hands. The titanium mesh did, but now I prefer this this concept: first regenerate and then place the implant. No, I have no experience with class 2 furcation defects. I have experience with intrabony defects. We did around 20 patients, and it was okay. It was okay. It was okay. What is my opinion on short implants? Short implants are a fantastic treatment option. Fantastic treatment option. Because we know that the majority, or not majority, all of the forces are up to the 4th millimeter. So that's it. Beyond the 4th millimeter, the implant has no function. So so short implants are excellent, excellent. And everywhere we can place short implants, yes, we place short implants to avoid, at least I like to avoid augmentation. How much vertical augmentation is possible? Well, I don't do so much vertical augmentations. I do them sometimes. But if you look at the studies by Urban, around 4 to 5 millimeter is the average which you can get. He gets even more, but you will say that 4 to 5 millimeters is the average what people can get. It seems that, well, this concept I basically utilize mostly for horizontal augmentation. And I'm waiting, I'm now waiting for vertical augmentations with this concept. So we're searching for patients that need that need vertical augmentations, and we will try with this concept, but for sure we will need tenting screws for this if we're going to use only collagen membranes. The difference in hyaluronic acid and implantology and fillers, it's not the same thing. So it's not the same hyaluronic acid. Don't use the one in the fillers. They're two different ones. Have I used a GBR with simultaneous and implant installation? No, no, not with hyaluronic acid. I did use it with other growth factors, but not with hyaluronic acid. The idea and the concept now is to first develop bone. Have you used PRP and PRF? Sorry to disappoint all of the people on PRP and PRF. I'm not a believer in these blood-derived constructs. The only good thing for me is that when you get the membrane, the LPRF membrane, it kind of enhances soft tissue healing, and soft tissue healing looks really nice. Another friend of mine, Snezhana, showing the journey. The ridge looks great. You have developed something much better than sausage technique. Well, thank you, Snezhana. I'm not sure if it's much better. We'll go and see the histology and we see. Is the acid helpful to stabilize the stability of the graft? Absolutely. The hyaluronic acid really stabilizes the grafting particles. Really, it really does. I never use synthetic bone. I cannot answer this. What is the commercial xenograft you use? Wait a second. It's oh my God. Sorry. Regedent is Regedent also distributes this bone. They come from Korea. It's a very nice material, very nice handling material. Do you always use pins to stabilize the resorbable membrane? Yes, I always use pins. Isn't it? Yes, it is very important to drill the holes in the cortical bone. Very important. And don't forget to do that. Always do that. Please always do that. What contraindications does it have? I don't see any. Hyaluronic acid is the major component of the extracellular matrix. Maybe some patients will develop allergies to hyaluronic acid, but since there is native hyaluronic acid there, I don't recall ever reading that somebody developed an allergy to hyaluronic acid. So I don't see any contraindications. So Jaime Montoya said he used a lot of PRF and have had amazing results. Is the hyaluronic acid comparable better? What is my experience? Sorry, PRF, I don't use it. I only use it for extraction sockets. I'm not a big believer in PRF. Although you can get very nice sticky bone with the PRF, so I don't know how is it comparable better. Really do not know. And unfortunately, all of the review articles say that there's a question does PRF help in bone regeneration? So it's still a question of debate. It's still a question of debate. Have I used for periodontal regeneration? Yes, we have been using it for the last 1.5 years, 2 years. Can Hyaluronic replace endogen periodontal therapy? Well, we'll have to see about that. Studies are on the way. We'll see about that. Again, what xenograft do I use? It's quite unbelievable how I cannot remember, after being 1 month at home and not being able to go outside to my office, how I immediately forget the name of the xenograft that I use. Contraindications. Okay, this is the same thing. You feel better than this bone when you, so there's a question, what is the feeling of the bone when I drill it? The bone is very dense. It's mostly cortical bone that you get. The bone is very dense. And this is what you actually always see when you drill in bone ridges that you regenerated with xenografts. So the bone is pretty dense. It's pretty dense. So did I use xenograft in socket preservation? Yes, I did. I don't leave it exposed. I cover it with collagen fleece. So that's it. And then I leave it that it heals by secondary intention. Do you use implant with a conical connection as flitch platform? Yes, I only use implants with a conical connection only. Did I use it in sinus lift procedures? Actually, I did, but this is not the topic. It seemed fine. What is the perfect ratio between xenograft and autogenous while mixing? Well, I don't mix it anymore with autogenous bone. So I see better results only mixing it with a xenograft. I know it sounds strange, but this is how it is. I always use the membrane without any exceptions. Contraindications, I don't see any. Do I see for gaining soft tissue volume hyaluronic acid? Well, not this one, not this one. So this one, I don't see any gain in soft tissue volume with hyaluronic acid. I don't know what is the difference between this one and the other ones on the market. I don't know. I don't know what is the main difference. I don't know any other country that actually produces, a company that actually produces hyaluronic acid for these indications than Regedent. So I really don't know. What about the intramural penetrations? I advise everybody to do intramural penetrations to allow the blood and the cells from the bone marrow, which we know that have receptors for CD44. And CD44 is the major receptor for hyaluronic acid. So, and this is probably why hyaluronic acid works very good, because then it probably signals to these cells to go outside, and there's signaling all around. So you've seen it that I not only pre-coat the grafting material, that I also coat when I place the grafting material on the recipient site. I also coat one more time again with hyaluronic acid to get an environment that is conducive for bone formation, and additionally to stabilize the grafting material because it acts as sticky bone. How is the quality of the periosteum at the second stage surgery? Very nice. The quality of the periosteum is excellent. It looks really very nice, really, really nice. In sinus lift, I think it can be useful. Well, you asked, one question is, what is the best Xenograft material in my hands? Let me not answer this question, okay? Because if I say something, then people will get angry at me and think so. I feel comfortable with the materials I use now. Okay, I tried many different xenographic materials, and some of them are really not so good. The handling properties are really bad. So I prefer to use this one that I showed you, and this one that I showed you, and the other one is BIOS. Have I used for periodontal regeneration? Yes, we did a series of around 20 patients. Any experience in advanced moderate periodontitis? You have some studies showing that it might be useful. We haven't conducted that yet, but my colleague from a university in Croatia, she is now wanting to conduct a randomized clinical trial on utilizing hyaluronic acid in patients with periodontitis. Do I use Ossex Plus? A very good membrane, very good membrane, very good, very good membrane, but very difficult to handle. Very difficult to tack it because it tears. So you have to suture this membrane, but a very good membrane. How do I harvest bone? Well, you've seen I have these bone harvesting drills that have a spring and a container. It's a plastic spring and a container, and you push it to the bone, and then it collects autogenous bone into the container. Do I recommend the same grafting materials with the use of a titanium customized GBR for vertical augmentation? Absolutely yes. So I think customized titanium mesh for vertical augmentation with this combination would be excellent for vertical augmentation. Is there a difference? There's a difference in, is there a difference between bovine and porcine grafting material? I would prefer, I don't know, my experience is mostly with bovine bone. I used long time ago, there was a company that doesn't exist anymore. They had porcine bone, and it was so. But there's always a question of virus transmission and prions and things like that. So that's a problem. Why do I use hyaluronic acid instead of Emdogain? Because I want to see a very simple answer, because we want to see if hyaluronic acid, since PDL has a lot of CD44 receptors in its site, you've seen that study. So we're interesting to see how hyaluronic acid is going to behave in periodontal regeneration. For bone, it's fantastic. has a bacteriostatic property. Do you note a decrease in infections? I had 2 infections in GBR procedures. Both of them were full maxilla cases, and one I showed you, and there was another one, and both were on the left side. I don't know why. So, but the good thing is that once we drained these abscesses, bone formation was excellent. So if we had this type of infection, if we use a non-resorbable membrane, we would probably lose a lot of grafting material. In this case, maybe because of the rapid remodeling, and these were quite interesting, these were late infections. They happened around like 4 months after the GBR procedure, which is quite surprising. They were not like 1 month or 2 months after the surgery. So I see excellent and beautiful healing of soft tissues after 2 weeks. Really increased soft tissue healing, which gives me a good feeling, you know, clinically good feeling. Yes, we will publish the results of the histology as soon as they get them. I have very little experience with the Shukran PRF except for extraction sockets. Do I have some complications like mucositis at the time of use? No, I don't see that. I don't see. Have I used hyaluronic acid in natural teeth with bone resorption? Yes, we did 20 case series on patients who have periodontal disease and intrabony defects. Which percentage of bone formation is seen after 6 months with the mixture? Well, we'll have to wait for the histology now, okay? But clinically, it looks beautiful. Clinically, it looks beautiful. But we will have to wait for the histology. We will have to wait for a little while, okay? But as soon as I have some histology, I will provide it to you, especially the first micro CT analysis. Hopefully, we'll start doing them in a month. We had an earthquake here in Zagreb, and the medical school and the dental school are completely closed, so it's not possible for us to go to the labs at all. So it will take some time to rebuild things. Okay, what are the survival rate? I can tell you one thing. So the question is, what is my survival rate of implants placed solely in xenographic bone during the past 3 years? Believe it or not, 100%. Not one single implant has failed up to date. So none of the implants, but I don't want to talk about that because knock on wood, because every time I say not one single one, then of course then one happens. But up to now, all of the implants successfully integrated and were successfully loaded. And now I have some patients following for 3 years, and it seems very nice. It looks very, 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 very nice. Another question is, what type of complications do you have observed? The complications that I observed, I told you, we had 2 infections during the 4 months after the surgery. And if we can say the complications that we didn't get enough bone, in the first cases that we did in the beginning, where we used more autogenous bone, that would be one of the disappointments in the beginning that I had in some places, in some sections. Is the application of hyaluronic in a case of flap dehiscence used for a split thickness flap and suturing would be sufficient? You know, I had some perforations of the flap when we did split thick, especially on the lingual side. And I can tell you that it healed exceptionally well when we place hyaluronic acid. So it seems that even in sites where we have some minor surgical complications at surgery, that it helps in recovering this small complication during the soft tissue healing. I've never had an exposure of a collagen membrane in this combination, okay? Never. When I used hyaluronic acid. Never, 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 never. I did have exposures when I used non-resorbable membranes, but when I used resorbable membranes, I've never had exposure. So, but if you have an exposure, there's not much you can do. You have to wait for it to heal by secondary intention. Don't try and resuture it. It doesn't work. Again, contraindications for the use of HNA. I don't any see. Is it possible that the detachment of the bone gained with regeneration occurs at the surgical time of implant placement. I've never seen that. I didn't see that. But if it's bone, then you don't see it. If it's soft tissue encapsulation of the grafting particles, then you can see that that's not bone. So, but what I've seen is that I frequently gain solid, thick, mineralized tissue. And you heard the sound, the knocking sound. That's how it sounds. If you don't hear the sound, then it's not bone, then it's usually soft tissue encapsulation of the grafting particles. I know the question, do I think with the mix with PRF? Try it, do the study. I don't know. Please do the study. I'm not interested in mixing it because I don't see any point, because the results look very nice. Okay, let's see another. So there's many times, do I have any experience with APRF? Which sutures do I use? I always use Proline suture, 5-0 and 6-0 suturing. What's better, resorbable membrane, non-resorbable? Well, in most of the cases, I use the resorbable membrane. For vertical augmentation, I think still non-resorbable is the main membrane. Again, have I considered combining LPRF with hyaluronic acid? You can try. It certainly will not give any harm. I've never used with a synthetic material, never. No, so I don't know how it happens, what will happen. How long do I wait? Okay, this is a good question. How long do we have to wait when we add hyaluronic acid and Xenograft to soak before we do GBR? You leave it for a few minutes. Leave it for a few minutes so hyaluronic acid precipitates on the grafting particles. But don't wait too long because it will get dry and then you'll have to add a little bit more. But you have a lot of that in the cartridge, you have a lot of hyaluronic acid. So don't let it dry. Don't let it dry. Okay. Again, the question, do I have scans 10 and 15 years of healing? No, I don't have scans of 10 and 15 healing. It's a new concept. I can show you only up to 3 years of follow-up. The grafting part, the material that is used is called the graft. The graft. Okay, now I remember it. So the material name is the graft. So that's the material. That's what I use in 90% of the cases. Of the last 3 years, in 90% of the cases, I use the material called the graft. Do I mix 2 different diameter of xenografts? Yes, the small ones and the big ones. Can one syringe be used with more than one patient? Generally, yes. Generally, yes. But you will see that you will actually, in the end, you will use all of the material or most of the material from the cartridge. You will use most of it. Did I use it with allograft? I did in some cases. I showed you the first case I showed you. It was a mixture of Xenograft and allograft, and looks worked. And I did 3 cases with allograft. Worked really very nicely. Very nicely worked. Can be used sutures to stabilize the graft? Well, no, can use the sutures to stabilize the membrane, not the graft. Do I have any experience in soft tissues with hyaluronic acid? I do a lot of periodontal plastic surgery, and we used, in many cases, hyaluronic acid for that. And we've got, in some of these cases, very, very nice results. Have experience of HyoDent in an open barrier technique, membrane exposed and socket preservation? Yes, it works fine, works nice. Although the superficial layer you will have the grafting particles not mineralized. Okay, so don't forget to remove these particles. So these particles, the superficial layer will always be encapsulated in the fibrous soft tissue. Okay, so remember to remove these grafting particles. Do I consider irrigating with an antibiotic in the surgical phases? Not so much, not the concept that I use, but you can, if you feel fine, you can mix it with tetracycline, the grafting material. That's what's usually done. Okay, let's see.
I think we come to the end of the, if you feel, one last maybe, and then I think we're gonna.
Okay, so what is the benefit of using hyaluronic acid if it takes the same 6 months as a bone graft to place an implant? Absolutely better results. Definitely better results, better remodeling, almost no soft tissue encapsulation of the grafting particles, and it's simply much better, much clinically, visibly, much better results than if you only use xenograft. Definitely much better healing, much faster healing, and much nicer healing. So that's why I use it almost on a daily basis.
Well, thank you very much, Professor, for your presentation and taking this extra time to answer all these questions. What we will do is shortly after this session, we will send an email to all the attendees, and if you have any questions, feel free to contact us. We will take time to answer you. Well, I wish you all a good end of the day. Or good start of the day if you're in Latin America. I'm thinking here about our Colombian friend in particular. And looking forward to meet you soon for next webinar, the 16th of April. Thank you very much, and well, have a good one. Bye-bye.
Bye-bye. Thank you very much, everybody, for listening. See you. Bye.